structure because particularly in Alaska, they're very isolated, some of these communities, and so the family structure is very important. But if the whole family's addicted, if all the adults in the family is addicted, then there's a problem that has to be addressed. So they have this whole family resiliency model there that I know has worked. But it depends on the community, if they're inner city, if they're rural, where they are, and what facilities and treatment centers are nearby, if there is. Anything that they can turn to. And as you mentioned, heroin is a huge issue now in the U.S. and the president has addressed it, put money behind it, and I know the money is primarily going for treatment, so we should see that trickle down to the local level, and churches can take advantage of it if they want to do major ministries like that. It's very important that they understand the scope of the problem when they become involved in it, though. If a church wants to just work on the policy advocacy side of things, then they can refer people to treatment centers that are nearby. That's kind of a long-winded answer, but there are resources out there to do that, and there are resources. There are funding resources through, in the U.S., it's through the Substance Abuse and Mental Health Services. There is funding to do some work as churches, partnering with the community resources that are out there. There's a lot of, now the paradigm has shifted that we aren't in silos, that we work together as stakeholders in a community, all the stakeholders, the law enforcement, the social services, the churches, and other civil society organizations work together to develop something so that we're not replicating something that might already exist. We're doing something that's seamless and is continuous amongst all the stakeholders in that community. Did that answer your question?
Thank you. Well, yeah, I was just also thinking about the avenues in which churches are more educated about these things.
Yeah, it has to be preached from the pulpit. One of the things I say, oftentimes when I go to a United Methodist church and they ask me to speak on this issue, they want to hear in conversation about individual approaches. How do you address this family here or that family there? And part of a sermon that I preach has a paragraph where I talk about, or a section of the sermon that talks about praying away drug abuse. Is that really effective? And the gist of it is, obviously it's not the sole source of addressing this issue, so you can't just pray away addiction. That gets people's attention when you say that in a sermon. And then you start talking about, and these are the effective measures that do work alongside prayer. But yes, certainly we know people who have turned around at miracle, but that's the isolated incidents. The comprehensive approach is critically important, and so prayer is one piece of it, but all these other things need to be in place as well. And it sometimes takes the jolt of those kinds of strong words in a sermon or in a Sunday school class, or when women gather. The United Methodist Women's Groups and AMZ, the women's groups are often the strongest groups in the church. So if they take it on, then oftentimes the whole church is committed to that.
Thank you. I don't know if you can maybe now briefly.
Okay. What you're describing is exactly the obstacle we have at local level, and at local level, you have the more conservative denominations who see this as a behavioral problem or a sin, or they see it as even demon possession is often in some denominations and faith groups. They talk about it as demon possession. It's very difficult to eradicate that particular theology and to show the difficulty of explaining a theology like that in a world where we need to love everyone and everyone is treated humanely. And to intervene when someone's a guardian, even worse, it's challenging. the hope, I guess, would be, especially in Canada, with your universal healthcare system, that they have interaction with that system, and that system helps to them to see that this is an approach that it needs to be beyond the church praying over the person, that they need to work at allowing the community to be a part of the healing process. But and it's a huge gap, and it's a huge problem. I wish I had the answer to that, because I struggle with it. Even the United Methodist Church, we have pockets of conservative churches, and the way they want to address this issue is very different than even our national position. So we have work to do to continue to educate. And the kind of data that we hear today needs to be translated into language they can hear and understand. And that's why I use those 4 theological concepts. Because basically what I did was, the presentations we heard, I translated it into faith language: abundance, community, humanity, and stewardship. So people in the pew are used to hearing that language. They understand that language. They may not understand the jargon of the UN or data, but they understand those words and what they mean for them, and helping to peel apart, what does abundance mean for you? You know, what does community mean for you? And then using that as a way to get in and have the conversation.
Thank you very much. I'm going to start with a question about statistics in children. I actually didn't quote any in my study, in my presentation, but I believe that part of the data that we collect in member states, as part of the World Drought Report, does sometimes have data that's disaggregated by age. So to the extent that member states actually report on the extent of drug use in the countries that they disaggregate it by age, then we then have some kind of picture of children that are involved in drug use. But I will say that not a lot of countries do this. The disaggregation by age is not consistent across the board. People also have sort of different standards as to what constitutes a child according to the convention or international laws. So the I would say the picture of data out there is not very good. And this is part of the reason why I emphasize the need to actually have a more robust set of indicators and data that is very clearly disaggregated by age and sex, so that we actually have a picture of what the involvement of children is. I mean, there have been some studies that have indicated, for instance, that children are more likely to take drugs if they are brought up in an environment where their parents also use drugs, for instance. We also have some evidence to show that there are certain factors that increase the likelihood that an individual may take drugs in the future. So that has to do with, for instance, the type of environment that he was raised in, certain risk factors that are present as well. So there is some research, but it has not been based on a very broad set of data that's been collected across the board. The recent UNODC report, the 2015 World Drug Report, talks about the usefulness of interventions and how certain drug interventions, treatment programs that are catered towards the family, for instance, an intervention at the family level or intervention at the school level has had positive impacts on girls and boys. So to that extent, we have sort of considered the impact on children, but more from the angle of what works in terms of drug prevention and drug and sort of treatment programs and interventions at the community level. On the question of Bhutan, to be honest, I don't think that we've actually looked at the issue of whether modernization and perhaps migration patterns from rural to urban areas has an impact on drug use. I mean, one could say that it does seem sort of logical that faced with stresses such as a change in environment, especially when you're facing cultural or sort of environmental stress factors that lead you to experience a lifestyle that's different from what you are previously used to, then that could be correlated with increased use of drugs, be it for experimentation purposes or so forth. But this is not something that we've actually looked into a lot. I would say that Bhutan, I don't think, is one of the countries that submits to us a lot of statistics and research data for our drug reports. I would encourage you to look online and see whether we've covered it in our previous reports. I don't think it has, and I don't think it has in the context of what you've described, which is the analysis of the link between a change in sort of social environment due to migration and perhaps a broadening of a social economic status in Bhutan related to drug use. So I'm not sure that we have that. I would also say that in general, I think everybody is supposed to need to know a little bit more about the issues and what we can do in that regard. And I really, again, will point to the importance of data and research and the fact that in countries, a lot of the systems that report information to the United Nations or even to their national authorities don't really do a good job in collecting this type of statistics in terms of the impact of the criminal justice system and the health systems on various groups in society disaggregated by age and gender. So I think this is actually part of how we figure out what's the best way to address these issues, sort of having the research base, the database out there, and then form interventions and best programs and best practices in this regard.
Okay, so it's 2 o'clock, time has come to an end. Thank you very much for being here. Along this presentation, I mean, we have touched upon issues such as women access to treatment or stigma or alternative development. But what is more importantly, I think we have touched upon the need to have gender perspective into drug policies to comply with the motto leave no one behind, right? So I thank you very much for coming, and